think we'll begin because I at least want to welcome everyone to the last workshop in the Responsible Conduct of Research series. And we have a wonderful presenter, Dr. Peter Elkin, and he is a definite aficionado, and not only aficionado, but a wealth of knowledge within biomedical informatics and data sharing and safe data acquisition and sharing as well. And he's really going to be talking a lot about that today, because in order to conduct responsible research, you have to definitely make sure your data is properly taken care of in order to make sure that everything is safe for the people involved. And so he's going to be talking about that. I do want to remind you that I'm going to be sending out the certificates of completion within the next 2 weeks. And then I'm also going to be sending out the micro-credentials for those of you who did micro-credential work within the next 2 weeks to the micro-credential office. And then the CME credits will also be sent to the CME credit office within the next 2 weeks. So all of that will occur within the next 2 weeks. And you should be receiving any of that based on if you've attended the series, all of the series, if you've done the micro-credential work, and the same for the CME if you've attended all the series. Now, if you did miss one in the series and you did the protocol that I sent you, that also counts, so no worries there. And I have that information down so that you can get your certificate of completion, micro-credential, whatnot. And I'm going to turn it over to our wonderful presenter, Dr. Peter Elkin.
Thank you so much for that lovely introduction. So I'm Peter Elkin. I'm UB Distinguished Professor and Chair of the Department of Biomedical Informatics here at the Jacobs School of Medicine, Biomedical Sciences at the University of Buffalo. And I'm a clinician as well as a researcher and an administrator. And I have spent a lot of my time looking at interoperability and what data, what safe practices of handling data are. And I am proud to say that this program has been an excellent teacher of responsible conduct of medicine and especially responsible data handling. And I think that you guys hopefully will enjoy the lecture and also have plenty of questions for me. So I have no disclosures with respect to this. The learning objectives are to ethically handle data, to understand one's responsibilities with respect to research data, to understand what constitutes unethical data management, so you have examples of what you shouldn't do, to understand HIPAA and the consequences of unethical data management, and then now there's some 21st century cures things I'm going to throw in there, and then to understand what fair data is, findable, accessible, interoperable, and reusable data, and then to understand what constitutes ethical data reporting. So Hippocrates, very long ago, stated, whatever in connection with my professional service or not in connection with it, I see or hear in the life of men, which ought not to be spoken of abroad, I will not divulge, as reckoning that all such should be kept secret. So this is an understanding way back in Hippocrates' days that we are pledged in health to hear things that are private and confidential, and we need to understand not that should not be divulged. And I think most people understand that, but we've had problems, and because of the problems that have happened, the HIPAA law came into being, and it wasn't really targeted at doctors or nurses. It was more, although it extended to them, it was really targeted at like secretaries, 18-year-old secretaries at an insurance company who might hear that somebody famous had this illness or another and had thought nothing of divulging that information to their family or friends or whatever, or on social media. And that was actually the impetus for the laws, but it has extended to us, and it shored up some things that were sort of based on your education before. So in order to understand what ethical data management is, I'm going to, start to look at what unethical data management is so that you get a sense of the controversy here. So you think about it, we're going to talk about fabricated data, biased methods, phishing to find positive results, not publishing negative results, unauthorized release of protected health information, merging unrelated data, splitting one patient's record into two research IDs, using unreliable data to generate reliable results. And of course, there's specific codicils for laptops. So let's start with fabricated data. So there's increasing pressure on faculty to publish and obtain grants. Many trials, prove that interventions just don't work. Recruitment to clinical trials is hard. Retention in clinical trials is also an issue, but your word is your bond. So this is a paper that was published in Diabetes that linked fecal transplants to obesity in rats. And this actually had the authors faked the data, and it had to be pulled. And this is what came out and published. And this goes in the newspapers as well as in many journals when you pull an article like this for false data. And basically, this person, Potty, couldn't get a grant ever again, probably lost their job, and wouldn't work in health ever. I mean, really ruined whatever education and background they had to this point by altering their data and publishing results that were untrue. So just don't do this. This guy claimed that 6 of 33 patients had responded to the test when only 4 people were enrolled in the trial. I mean, obviously, that wasn't hard to check up on. But even when you do things that are hard to check up on, people can do it. I mean, everything is public record. And even if you feel a lot of pressure, do not compromise your values for a quick result. More commonly, this kind of surreptitious and unethical behavior, there are a handful of cases, that's not most articles that are retracted by the main author of the paper because they found other information that made the data different or the conclusions different. And when that happens, there's a much more civil way of handling it. They're still published and everybody sees the retraction. And of those, believe it or not, only about a third of them go on to get published eventually. Now, when I first did this talk, that study had not been done, but it's very interesting looking at both ethical and non-ethical ramifications of practice of research. So biased methods include choosing your population on which to intervene. So if you can't claim that whatever you do works on a population that's different than the population that you had in your study, that is based on the inclusion-exclusion criteria of the study. People often choose their controls in a biased fashion to make them more likely to see a difference between the intervention group and the control group, and that's biased. Non-randomized trials where you pick the people, unrecognized bias can creep into this. So when you don't blind them, sometimes it's difficult to have a blinded trial because the type of intervention it is. And like if I'm showing somebody an intervention versus a sham intervention, it's very hard to fake a sham intervention. But you really need to try to blind the people doing the evaluation from looking at outcomes from what the intervention was. Some statistical methods are more sensitive than others. So some people pick which statistical method they're going to use based on wanting to get a positive result. And the interesting thing is that backfires most all the time, meaning that there's some statistician who knows about it. And I can tell you that we reanalyzed the data from a lead article in the New England Journal, and we published a letter to the editor, and the people who wrote the article had to praise us for helping them. I'm pretty sure they've got a picture of me in a dartboard somewhere and, you know, weren't too happy about the fact that they got found out, but they didn't really analyze their data correctly. And so they were at risk for it. And one of my colleagues at the time, who was a statistician, took great offense to this, and I helped him get the thing corrected. Some statistical methods are more sensitive than others. Oh, and type 1 error creeps into protocol. So type 1 error is the chance of getting a positive result by chance alone. So if you do a lot of tests, you just ask, let's say 1,000 questions of a population, you are at some point very likely to get some positive results that are based on chance alone. And if you're doing that, then there are a number of ways to correct for that. Fishing for positive results where the study was not architected to study that outcome or was powered to differentiate that outcome from its alternatives can lead to error. One of the ways of handling type 1 errors, you can look normally a p-value of less than 0.05 is considered significant. But if you have a lot of tests, it may have to do what's called a Bonferroni correction and use a p-value that's much, much smaller. Another way to do it is by doing subsampling of your population and running a large number of simulations. So if it's only positive by chance alone, and you run the simulations with the subsets of your population 100,000 times, the things that are by chance alone will fall out. Only the things that are in some way true findings will remain. And that's called a bootstrapping method. So an example here for this top part is if your sample size is here, but the population is here, you're really not representing that population well. We talked a bit about fishing for positive results. And so a lot of people publish, let's say the main outcome from your study is not positive, but you do find something in there. Is it okay to publish? Well, as long as you don't ask too many questions or you use a corrective approach like we just discussed, you can. But that means not that you just publish that finding, but you should also publish the main outcome that you had in your study as well. So you can say a main outcome was, mortality, and we did not find a mortality advantage, but we did find that the number of hospitalizations were less in the group that we analyzed, and that's fair game. You can do that. So this is a big one. It happens all the time. People don't publish the results if they're negative, and people have the general feeling that journals are much less likely to take a paper if there's a negative result. But we have advertised very heavily how important it is. Negative results tell the research community that you don't have to look at that anymore, that that's been looked at and was not true. And so you can go on and do other things. And if you don't publish your negative results, sure shooting, somebody's going to redo your experiments, and that's going to waste time and money. So I like it. But let's look at the data, okay? Let's say you're talking about top-tier journals, non-top-tier journals, and unpublished data. And if you have strong results, of course, you're much more likely to get it into a top journal. If you have mixed results, it's less likely, but you're still going to get published. Negative results, look at it. That it's much less likely to be published at all. And if it is published, it's much less likely to get into a top journal. However, it's very important to do it. And we've made journal editors aware that this is important so that they'll pay attention to it. And I'm the editor-in-chief of the Journal of Translational Research, and I can tell you that we will take negative papers. So let's talk about HIPAA. So HIPAA is a rule, it's the Health Insurance Portability and Accountability Act, but it had a administrative uh, area of the act, an administrative simplification area of the act. And one of the things it said is that you could actually have to pay money if you release records inappropriately. So let's say you have an unencrypted laptop, and that laptop has your patient data in it, and it gets stolen. For each, let's say you have 1,000 patients in your practice, and that laptop has them all. Then, if you are willful about this, found to be willfully neglect, and you couldn't correct it, you could have to pay as much as $2 million for this disclosure. And as little, if you even if you had no knowledge of it, it wasn't your software that did it, it was the EMR that you picked just didn't handle things right, and you still would have to have a minimum fine of $25,000, and that's on you as the clinician. So, and also, if you have a breach of more than 500 residents of a state or jurisdiction, you have to print it with your picture in the paper that you're a bad person and you let this happen. That is really bad press, and nobody wants it. Now there's a new thing. This affects not just individuals, but hospitals. There, in the 21st Century Cures Act, there's an information blocking codicil that says if you want to give your medical record to someone else and you want it in a reasonable way, then the hospital cannot deny it. And if they do, then they have to give it to you, or they can be fined for each person that asks and doesn't get it, $1 million for each occurrence. $1 million. That can add up pretty quick, right? So even a rich hospital, that kind of fine is a real threat. Let's talk about merging unrelated data. So let's say you're merging data from multiple practice plans into a database, and you have a bunch of John Smiths. How do you know if it's the same person? Well, you can use matching algorithms, which can tell you, but the fact of the matter is sometimes people make mistakes anyway, and you really have to be aware of it. In addition, there are error rates in our coding system. So we use ICD-10 to code for billing. It's also used for morbidity and mortality. And in the literature, they're wrong 23 to 40% of the time. In a study we did, it was 36%. And, it's there's a significant false positive rate as well. So there can be as much as 2/3 error in some of these coding systems. And lab names aren't standardized, and medication names are often not coded to the standard. And these things lead to people misunderstanding how many prescriptions people have had, what data is on hand. And we go to reason over this with decision support. You can imagine that this can cause real harm to patients. The other thing that can happen is splitting patients' records into two research IDs. So let's say you get the same patient, but from different practice plans, and they have different research IDs. And let's say that the addresses are typed a little differently, even though they mean the same thing, but one uses abbreviations, the other doesn't, that kind of thing. And they aren't seen as identical. Then what can happen is you can actually get two records, splitting the person's medical record onto two different IDs, and that can tell you that you have more patients than you actually do. And not knowing that a patient has died. So there's been variable success in getting death data from the CDC. New York State doesn't provide it regularly, and sometimes we don't get it here. When I started looking at our data in our practice plans, we had some patients that were over 160 years old. And unless we are given the best care ever, probably we didn't know that people had passed away, right? And so we started, to trying to clean up the data. Using unreliable data to generate reliable results. So if you put garbage in, you get garbage out. So that's why data cleaning and data imputation for missing data is really important. You should know your data. Understanding, having an intimate relationship with your data is the best way to get reliable results. And doing as many cross-validations with facts as you can. So if someone has a diagnosis of diabetes, it might just be that someone ordered a test for it. But if they're on insulin and they have a high hemoglobin A1C, now all of a sudden I've got somebody who's got a very high probability of being a diabetic. And there's a lack of interoperability between sources of data, which can make it difficult to combine data across multiple sites. So laptops, which includes the legislation for that includes smartphones, flash drives, all the things that are portable. And the first thing you should do if you're thinking about putting clinical data on any kind of mobile device is ask yourself, do I really need it there at all? And if the answer is no, don't put it on in the first place. If you do, and you really do need it, encrypt the data with a strong password. Do not store the password on the same device as you've encrypted the data. Put it on a separate device. Report immediately any loss of the device. If possible, scrub the identifiers prior to loading the data onto the mobile device. And know where your device is at all times. Do not use the same device that you're using for clinical purposes for things like family pictures, and social media and other things. Get a different device for that activity. So let's talk about what are best practices. Well, we're going to talk about HIPAA de-identification, trusted brokers, where two people are required to release data, either with IRB approval or public health emergencies. We'll talk about encryption, firewalls, two-factor authentication. We'll talk about fair data practices, data-driven recruitment, e-consenting, electronic data capture, case report forms, adverse event reporting, and general results reporting. So FAIR principles are findable, where the metadata are assigned a global, unique, and persistent identifier, that the data are described with rich metadata, and the metadata clearly and explicitly include the identifier of the data it describes. The metadata are registered or indexed in a searchable resource, so you can get at it. To be accessible, the data are retrievable by their identifier using a standardized communication protocol. The protocol is open, free, and universally implementable. The protocol allows for an authentication and authorization procedure where necessary, and that the metadata are accessible even when the data are no longer available, so that you can find a link to where the data was originally, so that you knew that it still had existed, even though it no longer does exist. And so you know what it was. So to be interoperable, the metadata must use a formal, accessible, shared, and broadly applicable language for knowledge representation. It's used vocabularies that follow FAIR principles and include qualified references to other metadata that's related to it. And to be reusable, the metadata are richly described with a plurality of accurate and relevant attributes. The data are released with a clear and accessible data use license. And the data are associated with detailed provenance, which means you know everything that happened to the data from the beginning when it was created to when you saw it that day. And then the data meet domain relevant community standards. So when you think about HIPAA de-identification, there's really two ways to do it. There are statistical methods under what's called expert determination, which kind of destroys the data, and almost nobody uses that. And then there's the safe harbor method, which is what's used most often, which is the removal of 18 types of identifiers. And it's supposed to be very hard to re-identify. as I said, expert determination, hardly anybody uses statistical method to just remove enough data that it's very hard to put it back together. Here are the identifiers for the safe harbor that HIPAA uses, which is what most everybody uses. Names, all geographic subdivisions smaller than a state. And you can give that back if it's a limited data set rather than this is for de-identification, complete de-identification. The geographic unit for all zip codes that are less than 20,000 people, you have to give a 3-digit zip. And then you can combine multiple zip codes if they're very small into one. All elements of dates except year, which you can keep in. Telephone numbers, vehicle identifiers, serial numbers, license plate numbers, fax numbers, device identifiers and serial numbers, email addresses, URIs, URLs, social security numbers, internet protocol addresses, medical record numbers. Biometric identifiers have to be scrubbed. It could be voice, finger, face print, whatever. Health plan beneficiary numbers, full face photographs of any comparable images, count numbers, any other unique identifying number, characteristic, or code, except as permitted by number C, which says that if you're over 90, you have to use 90 and above. And also certificate and license numbers. Now you can add back a meaningless research ID, and you need to do that. So if you've got data from today and you're going to relook and see if there's more data for that person at some later date, you need to be able to combine that with the right patients, and that's what the research ID is for. And that's why it's allowed in research by HIPAA. So often we use a trusted broker design in order to get access to the data. So as data is de-identified, a research ID is given to the data. The table is created on a clinical system that has a crosswalk between the real ID and the research ID. The crosswalk never leaves the clinical system. The crosswalk table is then encrypted and secured, and the de-identified tables moved elsewhere. And then or database is moved elsewhere. And then if you get IRB approval to do, let's say, a prospective trial on a cohort that you've looked at retrospectively, you can get IRB approval to do that trial, and then you can go back and unlock who the real IDs were for the people that met the criteria for your inclusion-exclusion criteria for your approved IRB protocol. The other way you can get at it is a bona fide public health emergency with a request from a public health authority is allowed. So let's talk about encryption. We made a big deal about that. So it takes the NSA about 24 hours by brute force methods to break a 48-bit encryption key. And for a long time, you couldn't let anybody ship any data out of the country with stronger encryption than 48-bit. But we impressed upon the NSA that healthcare is a more important goal than security sometimes. And so they were afraid that terrorists would be sending messages and healthcare information. Now we can send 256-bit encrypted data overseas, and it's allowed. So it turns out the encryption routines don't slow your computer down much anymore. So there's no excuse for not doing it. Everybody should encrypt their computer. Individual files can be encrypted if you don't want to encrypt the whole thing, but it really doesn't slow your computer down much. And the goal is that the cost of decryption is greater than the value of the data to someone trying to get at it, and not to make it completely inaccessible, because the utility of being able to get at data and the security of making it secure are at odds with each other. So I want to talk about the public key infrastructure, which is one of the ways that we do better at securing data. So let's say I'm going to contact one of you guys. I'll pick on a name here, Michelle. I'm going to send Michelle a message. So I would encrypt that message using my private key and her public key. And she would decrypt the message using her private key and my public key. So that layer of extra protection is that she and I have already made the agreement that we would be sending information back and forth between us. And so she had my public key and I had her public key, so I could do that. Of course, this public-private key infrastructure, which is the most the most secure of the ways to send data, has been also used by hackers to send ransomware attacks. And if people were around when we had our ransomware attack at ECMC, it encrypted all the data, and they would give them the decryption key if they paid them, and they didn't pay them, and it cost $10 million to set it right, and about 4 or 5 months of work. Turned out the cost of the key to get rid of it was only about $30,000 at the time. But people had a real problem with, dealing with terrorists. And these are the FBI's after people who do this. And as you can tell, there have been fewer of these attacks as of late. Let's talk about firewalls, which inhibits hacking. Firewalls inhibit unauthorized people from getting into servers they're not privileged to access. So knowing, you should have more than one way to stop people from getting into your system. So having a user ID and password to access the site and having it for private and strong is a good idea. But also, if you know who can access your system, you can put them on a list, and if someone from outside that list tries to access the system, it can hold it out. And you need not only the IP address, but also the port that you'd be using, and that's not advertised very much. So it would be something that would be granted to you from the people who provide the secure input to the system. And of course, you want two-factor authentication. We use it at UB. Those of you who use Duo Mobile for authenticating to get into UB resources, that's a two-factor authentication. It can be a physical key, or it can be, a physical token. I got one of those somewhere. Let me find the thing the NSA gave me. Where can I find it? Here we are. Yep. So can you see I'm not going to press it, but here's a physical token that you can see on the screen here, which gets me into the very secure servers like the DoD and whatever. But also sometimes they do it through the cell phone apps like I do for the hospitals. Know who is the person storing the data, know who is accessing the data, and avoid identity theft reaching your data. So it turns out that there's a lot of identity theft on the web, and you just need to be careful with your private information and not give it to people. Don't put your credit card or your social security into any site unless you're absolutely sure that they're legitimate. And people get hacked all the time. And there's a huge investigation going on by the FBI right now of doctors who are called by people pretending to be DEA agents, and older people in your practice where people are trying to take their savings. And it's just disgusting, but it happens and we have to be vigilant. This was on the door of one of our politicians from our region in Washington. This is actually the actual ransomware message from ECMC that they got from here. So what they wanted was, this was Bitcoin at the time. They wanted 1.7 Bitcoin for this. 24 Bitcoins for for release of all the data at ECMC. It turned out one of the doctors had gotten their computer locked also, and they spent the 1.7 bitcoins, which at the time was maybe, $1,500 or $2,000, and they got a decryption key and it worked, and then their computer worked, and they shared the key with ECMC, and ECMC used it, and that caused a chain reaction which deleted a whole bunch of the data because it wasn't the right decryption key. So don't assume just because they're bad people that they're stupid. That the people doing these kinds of attacks may not be stupid at all. Actually, they may be pretty bright and anticipate your nefarious moves on everybody's part. Thought that was something you don't see every day, is the actual ransom note. Anyway, so this is something that we do NLP, natural language processing, in my lab, and we pull data out of clinical notes. And this is a note from a patient's record with a bunch of SNOMED codes in it and where they are in the record. And I'm sure you can't tell me what those SNOMED codes mean altogether, nor can you tell me who this patient was. So I believe that it would be more acceptable to the country to send files like this around than notes from people's records. And I think this would be an okay way to get knowledge about patients. And this is very deep knowledge. It tells you the patient, the document, the section, subsection, problem, sentence, compositional expression level detail, and then the actual named entities that are found. And then it tells them whether it's a positive, negative, or an uncertain assertion. And then semantic triples are formed where needed. So I think this is very robust data and would be a good alternative. This is the data interoperability scheme that we have at UB, and this talks about layers of interoperability, including physical, platform, standards-based, and application-based interoperability. Next, we're going to talk about data-driven recruitment to clinical trials, because this is coming and there's new methods for clinical trials now. And the FDA is accepting real-world evidence as part of a clinical trial. So more and more people are going to be getting the follow-up data from the EMR and seeing the patient rather than having to see them by a study nurse for the study itself. So this is inclusion, exclusion criteria for the study and what critical question is being asked. We have a tool called the Biomedical Informatics Investigator, which allows you to look for anything that you want and in our clinical data, and it immediately gives you a result. And then you can make it as complicated as you want. And then it'll give you the distribution of race, ethnicity, gender distributions, and age distributions. And this allowed us to do 5-minute studies. So this is a study answering the following question. If you get the flu shot and you still get the flu, did you get some partial protection or is it just miss? As you may know, only certain serotypes are put into the flu vaccine every year. And the way we went and approached this question is we wanted to see if there was a difference in the rate of complications of influenza if you were vaccinated or unvaccinated and you had influenza. So everybody had influenza, some were vaccinated, some weren't. And we looked at the rate of pneumonia and we accounted for Pneumovax. What we found was there was absolutely no difference in the rate of pneumonia in the group that was vaccinated and the one that was unvaccinated. And then we thought that was too easy. So we said, okay, we've got a bunch of people who are smokers. So these are people who had influenza, pneumonia, and were smokers. How many of them did we tell to quit? And only about 2/3 were told to quit smoking. And so we put programs in place to try to fix that. And we did and published another study where a smart clinician said, I think that my patients who come in with rosacea, which is a reaction, a an autoimmune problem where you get a facial rash are more likely to have obstructive sleep apnea. So we looked at the people that had rosacea and the people who didn't have rosacea and what the rate of obstructive sleep apnea was. And it turned out that only 2.6% of patients who did not have rosacea had obstructive sleep apnea, but 8.8% of the people who did have rosacea had obstructive sleep apnea. So this is highly statistically significant, and the relative risk was 3.4 times. The number needed to test to understand this was only 12. Anything less than 50 is wonderful. And so everybody who has rosacea should be asked the screening questions for obstructive sleep apnea. And we published that just from this retrospective data. And there was no articles before ours in the literature. So now we're going to talk about e-consenting. So in e-consenting, informed consent is a process, not just a form. People must understand what they're signing. The information must be presented to enable persons to voluntarily decide whether or not to participate in the research. It's a fundamental mechanism to ensure respect for persons through provision of thoughtful consent as a voluntary act. The procedures used to obtain informed consent should be designed to educate the subject population in terms of what they can understand. Therefore, informed consent language and its documentation, especially explanation of the study's purpose, duration, procedures, alternatives, risks, and benefits, must be written in lay language, and it must be understandable to the people being recruited. Written presentation of information is used to document the basis for consent and for the subject's future reference. This consent document should be revised whenever deficiencies are noted in the document or when additional information will improve the consent process. So there are things that you might not think about that you have to think about. The use of the first person, like I understand that, can be interpreted as suggestive and may be relied upon as a substitute for sufficient factual information and can constitute, therefore, a coercive influence over the subject. Describe the overall experience that will be encountered. Describe the benefits that the subject may reasonably expect to encounter from enrolling in the study. Describe any alternatives to participate in the research study. The regulations insist the subject be told the extent to which their personal identifiable information will be held in confidence. If research-related injury is possible, and that's just not physical, it could be psychological, social, financial, or otherwise, then an explanation must be given of whatever voluntary, not only whatever their risk might be, but in addition, what compensation is available to them and what treatment will be provided if they have a complication. Notes the regulations do not limit injury to physical injury. The regulations prohibit waiving or appearing to waive the legal rights of the subjects. You can't say to people, it's okay if we kill you on purpose, you know. It's not lawful to say that sort of thing either. And the regulations provide for the identification of contact persons who would be knowledgeable to answer the questions of the subject about the research, the rights of the research subject, the research-related injuries, and these three areas must be explicitly stated and addressed in the consent process and documentation. And there must be a statement regarding voluntary participation and the right to withdraw from the study at any time. So we're going to talk about electronic data capture. These are the systems that take research data and store it for use in the study. And they should do, you guys should take reasonable care with usability if you're creating electronic data capture systems, and that means using a user-centered design approach. As they are the data collection method, they must be referenced in the IRB document. New forms should undergo usability testing because not all forms themselves are usable. Data types and question types should match your IRB approval. Questions should be codified in a standardized coding system. possible answers should be codified in a standardized coding system. And then the groups of questions that have been validated cannot necessarily be delinked or reused, as they may not have the same reliability if no longer linked together. So the whole idea is to make this useful, and that includes two parts: utility and usability. And usability is easy to learn, efficient to use, easy to remember, few errors, and subjectively pleasing, right? People want to say they work on it. Case report forms are reports that is required to file a description of any unanticipated problems that arise in the research. That includes a data breach and any adverse events that you find. This is an example of one of the case report forms that I found on the CDC site. It's a babesiosis study. Give you a chance to mull that over a little. As you can see, it's not very user-friendly. I'll let you read the joke. Adverse event reporting, if it could be related to the research itself, you must report it. That's the key. And this is a flow diagram that basically says that. Reporting results, always report or publish your main outcomes. Keep sub-analyses limited to what you're powered to predict. Never let your conclusions extend beyond your data, which many young investigators get wrong. And make sure that your methods, results, abstract, and conclusions match in both breadth and content. So we've been able to get increasing results reporting over time, but not perfect. So if you talk to Noam Chomsky, he says that ChatGPT is just a plagiarism engine and not an artificial intelligence. There's an argument, of course, on the internet and other places in academia about what these tools are. And translational science uses translational informatics for the most part. So I'm going to tell you a little bit about deep fakes, because these can be part of what you need for responsible conduct of research, not to do these things. Both of these political candidates believed that they were doing the right thing, and neither of them thought they looked like that. And you can even bring back people who passed away with the generative adversarial networks. And once you get the pictures, you can use them for deep fakes. And actually, there was a big judgment recently by the negotiations of the actors union that if they actually their likeness is used in a movie and they're not in it, they still have to pay them the same amount they would have if they were acting in the movie. And that's a big step forward to keep people honest. So how's all this done? Well, what happens is, let's say you have a picture that's sharp and you start adding noise to it randomly. And what happens is the model learns what the picture looks like with noise backward and forward. And what that does is it allows the system that's using this information to actually clean up images, or to take images and make them into something else based on this kind of diffusion pattern. So here's an example. Here's me, and I'm human. I go through the machine, and this is what it thinks I look like. And then it goes back to the discriminator, and it keeps iterating until it gets closer to me. Eventually, it gets something that's pretty good, and then you could take me and put me anywhere. So instead of here, now I'm at the sunset, right? I've got sunglasses on instead of regular glasses. and this system can do that. This is an upper level ontology. It's the basic formal ontology, which we use in Buffalo, and the ontology of general medical sciences, which is the course of illness ontology that we use. This is SNOMED CT, which is one of the ontologies that I've been often using. What we've done is we've taken authoritative material in medicine, and we've looked at it, used our NLP software to create codes for semantic triples and then sentences, and use these to train machine learning algorithms. So this particular machine learning algorithm is a set of embeddings that that actually first encoded SNOMED Loinken norm, then encoded sources of medical knowledge in it. So clinical guidelines, toxicities, it looked at a drug database, it looked at many other authoritative areas, the medical literature. And then what we did was we added data to it to predict overdose. We had a population of people who were at risk for opioid use disorder, and we wondered if we could predict those that were going to have overdoses and also death events. And we very, very accurately were able to do that, and we were actually able to do it much better with the pre-trained embeddings than without. So we trained the model on the same data with normal machine learning training without any pre-trained embeddings. And then we did the same thing with pre-trained embeddings, and it got a much better result. It was not only more accurate, but it was less biased. So the things at the top are with the semantic embeddings, at the bottom without. And you can see that as we take away data or take away facts or take away or add bad data in, which is the bottom, we actually degrade much more slowly than our counterparts. Get that to move again. Okay, yep. I think it went backwards. So then we come to large language models. So in deep learning. So, when we started the project before, we didn't have large language models, and they came on the scene, and people have been talking about how useful they are, and we wanted to see. And so these are often chatbots, but they do plagiarize and confabulate. They do create fake data, and they are not able to take responsibility for what they write because they're machines. Often they have poor usability, and they can create harm from misinformation. So we created a system we call semantic clinical artificial intelligence, where we actually took a bunch of authoritative information and we used it to pre-train the embeddings, and then used that in input to the large language models in order to create better answers. So for example, let's say you have a question, we would parse it with our NLP and create semantic triples from it. Then this would go into the set of embeddings that we had and find all the other triples that were related to the ones that we had. And then what you do is you take those now greatly increased set of triples, and you'd actually generate a large amount of pre-training text. And what happens is that pre-training text and the question would then go into the large language model and provide an answer. This is an example of the LLM which we used, which was the Llama 13 billion parameter model, to answer this clinical question. And it actually gets the wrong answer. So this is a 24-year-old recent graduate from college, comes to the office with a 3-year history of frequency of urination and occasional incontinence when she travels. This happens right before she's going to travel and a day afterward. And obviously, those of you who are following this know that this is a behavioral thing, right? And yet it said that reassure the patient that her symptoms will resolve in time was the answer that the LLM gave. And when we put the semantics in, we gave content that looked like this to it, but it was really much larger. It's about 44 kilobytes of total content. And the right answer was A, recommend behavioral therapy for this. So we took the United States medical licensing examinations. There's 3 tests. One test you take when you're a second-year medical student. The second you take when you're a fourth-year medical student. And then the third one you take when you're an intern. And so you can tell they get, progressively more clinical in nature. And we did the same method. We used the regular large language model, and then we used the Psi version of that same large language model. So for the first test, which was the more basic sciencey one, there were 87 text-based questions. The ones that were based on images we couldn't do yet. We don't have that built yet. But we used all the text-based questions. The large language model got 29 right, and the Psi model got 48 right. And this was highly statistically significantly better. In the second test, there were 102 text-based questions, and the large language model got 35 right, which is about 35%, not much different than before. And the Psi model got 49%, slightly less than before, still highly statistically significant by the McNamara test. And then for the third test, the most clinical of them all, the Llama model got 45 right, or 37%, and the Psi model got 55% right, and that was also highly statistically significantly better. None of the models yet were able to pass the test, which is a passing grade of 60, but 60%, but they're getting there. And we have a new implementation of this that we're building that we are wondering if it will get over the 60% pass rate. So there's this great quote by Socrates that I like, that I wanted to share with you. That is, strong minds discuss ideas, average minds discuss events, weak minds discuss people. Be a strong-minded individual. It's my hope for you guys. So now we're going to go through some cases, and I want someone in the group to read the case and then give us the answer. Who's going to do case 1? Then we'll talk about it.
Cedric, do you mind reading this one?
Sure.
Thank you, Cedric. I appreciate it.
So a young researcher is analyzing identified data from a clinical trial on her laptop, which she carries in her backpack. She always keeps her backpack carefully protected, and she stops to go out to dinner with a friend, and she locks the backpack in the trunk of her car. After dinner, when she comes back to her car, the trunk was broken into, and her backpack with the laptop is no longer present. She had 430 patients in the registry. The laptop was unencrypted, and therefore she must report the breach to the study and the newspapers. She had 430 patients in the registry. The laptop was encrypted, so she did not have to report the breach to the study and the newspapers. She had 230 patients in the registry. The laptop was encrypted, so she did not have to report the breach to the study and the newspapers. Or she had 260 patients in the registry. The laptop was unencrypted, so she had to report the breach to the study, but not to the newspapers.
What's the right answer? Do you want to take a guess, Cedric? Or
my guess would be probably number 1. It depends on exactly where these patients are coming from, whether or not she has to report it to the newspapers. But I believe number 1 would be the closest.
Okay. Well, it's not a bad guess, but you need 500. If you have more than 500, you have to report it to the newspapers. You certainly have to report it to the study. So the one, number 4, you always have to report it to the study whenever you have a breach, for no matter what. You never can leave it without being reported. But you don't have to report it to the newspapers till you get to 500. And if it's encrypted, even if it's over, you don't have to report it if it's 256-bit encrypted. So I want you to remember the number 500. So if you even have to put these things on your computer, your risk goes up significantly, and you always should be encrypted. Let me
So
go.
500 is our key there. So that's really important to know.
Yeah.
And
So let's see if I can call. Anybody want to volunteer to do the next one? So it was painless, right? How
Yeah,
about,
I'm happy to read it if you, this
oh,
is Michelle.
thank you, Michelle.
So, welcome. John is a research assistant and his boss asked him to provide the study data. He's a member of the studies approved by the IRB and has access to the data. However, he has class and cannot take the data to his research mentor who's working at his office across the street. He puts the data on a USB drive, thumb drive, and asks a fellow student, Doug, who is not in that class and not part of the study team, who is willing to take the drive over to the research mentor in the next building. Doug does not look at the data on the drive and delivers it to the professor in the next building, who thanks him. As Doug did not look at the data, there was no data breach. That's choice 1. 2, as Doug is a student in the same department, there was no data breach. 3, Doug is guilty of a breach only if he copies and sells the participant's social security numbers to an identity theft ring. 4, Doug is guilty of a data breach and it must be reported. 5, John and Doug are both guilty of a data breach.
So what do you think the right answer is?
I think it's difficult. I think John was reckless in the way he handled the data. Is there actually a breach in that? Did anybody use data that they didn't have? My guess is 5, but I think there's some ambiguity here.
You're a good guesser. So it is 5. I'll tell you why exactly. So when John handed Doug the data, he was committing a breach. He should not do that. Then when Doug accepted the data, and even though he handed it to somebody, he kept it himself and carried it across the street, he was guilty of a breach because he accepted data that he did not have a right to have at all. And even though he gave it to somebody who did have clearance, right? They were on the IRB, he was illegally in possession of the data as he walked it across the street. And this is how the law enforcement will see it if you're ever in a case. So even if it seems like, this is going to take 2 minutes, it's a little thing, this guy's reliable, he's not going to look at the data. The only people who are looking at the data are the people who have rights to see the data. You can't handle and you can't have the right to see data or control over seeing data if you're not on the IRB. And I think if you think about it that way, it makes perfect sense. And it's really easy to think about what the right thing to do is. And always do the right thing. And if someone, it is, whether it's this or it's something else, there are people who will always try, no, there are people who, everybody runs into somebody in their career who wants them to do something that is a bit shady. And you need to understand it so that you know to say, I don't feel comfortable with that. And it's perfectly fine to do that. And sometimes the person who's giving you direction is your boss. And it's hard to do. But believe me, whatever you do is on you. It's not on somebody else, even if they tell you to do it. So remember, always try to do the right thing, regardless of the pressure not to. It'll stand you in much better stead. Thank you. Great job. Okay, case 3. All right. Who wants to do case 3?
I'm happy to read the next one.
Oh, thank you. Thanks, Juan. Appreciate it.
Case 3. A researcher is combining data from 2 hospitals Hospital A is an academic center and Hospital B is a community hospital. The researchers merged the common patients and merged the problem lists, noting exact matches between the two institutions. After electronically merging the data, the researchers asked, on average, how many problems do patients have in their problem list in the merged database. 1. The researchers report 12 diagnoses as they count every line. 2. The researchers report 11 diagnoses as they had one exact match which was returned. 3. They report 6 diagnoses because they can ignore the data from the community hospital. 4. They report 7 diagnoses because they cannot match LDSD and YHA class 3 exactly with CHF. 5. They will get the wrong number to report in the research study, and that can affect their conclusions. The publication will later, I'm sorry, I cannot read the last line.
Oh, will later be retracted when another team reanalyzes their data in a very embarrassing way. So what do you think the right answer is? Or what do you think the issue is? Let me just put it that way.
I mean, if you are going to combine data from 2 hospitals, you need to be careful with not merging data from different patients or having one patient split into 2.
That's true. But also here, what you see is that in the community hospital, they have generic names, very higher level in the hierarchy names for what the patient's problems were. The same basic problems with more detailed descriptions are in the academic center, right? So where someone just said headache, in the academic center, they said cluster headaches. Only obstructive sleep apnea was the same between the two, and they were much more specific terms. So what you have to say to yourself is this actually the same thing better described, or are these two different representations with two different problems in the same hierarchical class of problems that the persons have? So in either case, you could make a decision that these are really only 6 problems that the patient has, and they're just more detailed descriptions in the academic center than they were in the community hospital. And these are real live data problems that people think about. And if your study is reporting how many problems people have, it directly affects your results, right? So the key thing is to document your methods of how you're combining the data, and then what you did at each step, so that anybody who wanted to understand how you came to your conclusions can understand how you got there. This case teaches you about data provenance, that you need to have data provenance is when you know everything that happened to the data from the minute it was generated, or even how it was generated, to the data that you look at eventually. And in order to give confidence in your results, when you look at data that is taken out of an EMR, you really need information on the data provenance. And there's actually a W3C standard called the PROV standard, which is a way to document data provenance. Anyway, it's kind of a fun thing, and I thought this would be a fun thing to discuss in terms of research. I'm just going to do some conclusions, then we'll have a discussion. So, things you should remember about responsible handling of data: always encrypt your research data. Never send the password with the encrypted file. Always send it separately in a message in a different way if possible. Do not write password in the message, the word password, because scraping programs will find it. Use a trusted broker methodology whenever possible, so that it takes 2 people to unlock data, and that no one person can do it themselves. So an example of that might be where I have access to the data, but somebody else has the encryption key to open the data, and they don't have access to the data. Take time to understand your data, because without it, you can misinterpret things. Do not report false results. If you're not sure about the results, just don't report it. Do not let your conclusions, this is one that junior investigators miss all the time, where the conclusions of their article outstrip what their data shows. They get excited about their work and they want it to mean more, and they think it could mean more, but they don't have data to support it. This is not a good thing. And you end up losing, one, people won't accept your paper, and two, it can hurt your reputation. Remember your HIPAA penalties, that you can have very high fines per individual patient that's disclosed, and also that if you disclose more than 500 patients, you need to report it to the newspapers. And avoid local PC databases whenever possible. Just, put your data on a secure server and VPN in and get it when you need to do your analysis there, and just take off aggregate results for your papers. It's safer for you and puts you at less of a harm's way. But I would always encrypt any drive that you use. If you can avoid mobile data wherever possible, and encrypt your drives anyway, even if you never put data on it, because people will ask you if it's encrypted because of the law. Responsible conduct of research requires responsible data handling. Responsible data handling involves the generation, storage, transfer, and reporting of data. That a clinician's license is the one that's online if there's a HIPAA breach. So if someone breaks into Kaleida, a building I've never heard about, and taps the EMR and gets my patients, the person who's responsible is still me, because I'm the one with the medical license. Responsible data handling is every researcher's responsibility. This is one of the core responsibilities of being an investigator. And if you ever put in an IRB, you know how seriously compliance takes that. And we, the Department of Biomedical Informatics at the University of Buffalo and the CTSCA, are here to help you with your responsible data management needs. Let us know how we can help. This is my email, elkinp@buffalo.edu. I'm easy to get. And I want to thank you for your kind attention, and happy to stop sharing and answer any questions that you may have. And I think I'm on time and under budget, right?
Are very good. Thank you. And the case studies were excellent.
Thank you.
Thank you very much for adding those. I appreciate it. We do have one question in chat, and it is, can blockchain be used to send sensitive data?
So if you have an encrypted private blockchain. So the thing about blockchain is it's open. It's an open ledger. And what it does is it secures things, meaning that all of the cells that got you to a particular block create a code that is unique to that progression. So if you were to alter a cell, so let's say my bank says that I have $100, and I think it would be nicer if I had $100 million. So I go in and I type in a few more zeros. None of the serial numbers, the blockchain would verify with that in the blockchain account. And so it would be clear that was altered. Now, there is one weakness that's well known of blockchain, and that is the 51% attack. So the way it knows this is, let's say you change a block, and then you change every block after it. You go in and you change it all. So now you can't calculate that it's been changed. So what it relies on is each blockchain puts thousands and thousands of other copies, places you don't know about on the web, but it knows about. And it goes back and checks it. And if the majority of them disagree with what you've put in, then it will say that yours is fake. But let's say you populate the blockchain locations with more than 51% of the blocks, all of a sudden you become truth, and you have $100 million in probably crypto, but $100 million nonetheless. Um, and that's one of the blockchain problems. So people have gone for things like protected health information to private blockchains where it's not open, you can't see it, and therefore you don't know what to do, and you really can't access it without permission from the trusted broker who is running the blockchain. It's a little slower, and obviously, as you know, as you have more blocks, blockchain becomes more computationally intensive. So it hasn't taken off for banking quite as much as they had hoped when it first came online. But I do think that there are going to be uses for security in healthcare that we, especially with letting people exchange genetic information, which is very identifying, to keep highly sensitive portions of the record extra secure. And I think that that's coming, and people are working on it becoming more efficient with GPUs and so forth. I hope that helped, or if that was too jargony, just tell me and I'll try to reword some stuff.
I think it's okay. Please tell us if you need more information in that one. I don't see any other questions. Does anybody have any questions? And please remember that the medical bioinformatics department is there to help you, definitely. And Dr. Elkin does a great job of getting back to people. Let me tell you that.
Thank you very much. I really enjoyed the students and want you guys to all have charmed careers, and anything I can do to keep you safe and to make your life successful, let me know.
Great.
Pleasure. Thank you, everybody. I hope you guys enjoyed the talk and enjoyed the topic.